Let's discuss the disruption of long-term care in Toronto. Stemming from the increasing aging population in our nation, we will be going over the lack of long-term care facilities for seniors and the need for us to find socially innovative ideas in addressing the issue, and exactly how social work can be a part of that solution in addressing this need. Taking a closer look at the data from the Ministry of Health and Long-Term Care, we can see that since 2012, the median wait times in days has continued to increase and is now a whopping 223 days for long-term care within the GTA. Also, seniors want to age in place because it is a comfortable environment for them to stay in their homes. They have feelings of independence, familiarity, safety and security, close proximity to family and friends, and the convenience of services that they've known. But they may have concerns about safety, getting around, and other activities of daily living. Some things seniors may say include, "I have lived here for over 40 years and no other place will seem like home, but the stairs are getting harder to climb." Since people are unable to move into long-term care, it seems more like they are being stuck in place. Older people who live in an unsafe environment or areas with multiple physical barriers are less likely to get out and therefore are more prone to isolation, depression, reduced fitness, and increased mobility problems. Getting creative with finding a socially innovative idea, our 2015 census tells us that 35% of seniors live alone in apartment buildings. These are communities that are not built for seniors, but now have a very high number of older adults. In other words, they have become an emergent, naturally occurring retirement community, but not built to be. So why not apply a social determinants of health approach and leverage the existing environmental features? Establishing a social work model, we can pilot 5 buildings that have a minimum of 35% seniors residents and label them a naturally occurring retirement community. As a designated NORC, a social worker would do a friendly visit to all seniors to offer support, and after consent would conduct an assessment to identify their physical, environmental, psychosocial, and health needs. An on-site support network will be established in each building, fully equipped with variations of community agencies that offer the supports and services to meet the identified needs. Examples include Fred Victor, Coda, Loft, Wood Green, among others. This would include having case managers on a daily basis, offering services like counseling and helping with document review and income. It would also have a calendar of social events such as communal dining, games, and exercise programs. A clinical team will also be established, including a hybrid model in which student medical doctors would do rotational visits with seniors. A closer look, how will it work? Once a social worker visits seniors in their homes and has captured the needs of everyone, the physical modifications will be brought to the attention of building management for these maintenance repairs to be made. Some changes will include installing grab bars, rolling showers, lowered cabinetry, heightened toilets, etc. Establishing a network of social service provision will be funded through the local health integration networks, the LINs, as a reallocation of funds from parts of the Ontario health system. The social worker will be paid for through the long-term care funding and will lead the coordination of establishing the network and bringing together the management and people to the table to get the MOU and agreements in place. The medical team, as mentioned, will be brought in through partnership with the University of Toronto as a place where their medical students who are in need of practice hours can provide medical care to seniors in the buildings. In short, the integrated model brings varying partners to the table in which seniors receive wraparound supports and services in their homes so that they can really age in place. So how will this be funded? It is quite simple. Reallocation of funds within the Ministry of Health and Long-Term Care. It really is just about a cost-benefit analysis. Bringing the services from an institutional setting to seniors at home will cut costs and save spending on hospital care and long-term care institutions. The Ministry of Health will cover the cost of the social worker, and all unit modifications and repairs will be paid for by the landlord and building management, with the support from the social worker to apply for many tax credits. The community-based agencies will be funded through the Ministry of Health system, through the LINs, which is the local health integration networks, which will include money for rent so that they can also pay that to the landlord. The medical team will also be paying subsidized rent for use of space. In short, it is a sustainable funding model where everyone benefits. It is sustainable, replicable, and scalable. With the proliferation of NORCs, i.e. naturally occurring retirement communities, there will be a reduction in the need for long-term care facilities, and more funds can be made available to expand the creation of NORCs. This will also see a reduction in the need for emergency room visits, which currently cost $842 per day for someone staying in the hospital, and $126 per day for someone in a long-term care facility. The cost to keep someone in their home with the social work model proposed is only $42 per day, making this easy to replicate and scale. The socially innovative idea is disrupting how we think about long-term care, moving away from the already established residential facilities that are unable to keep up with the demand to bringing seniors the services that they need. In short, NORCs aim to bring the services to seniors in their homes. The model can be evaluated and measured in many ways. 1. Seeing the reduction in repeated calls to 911 for primary care, an increase in the communal meal programs within the buildings, a reduction in wait lists for long-term care facilities, an increase in social programs and recreation activities, increase in clinic visits with the medical team on site, and a reduction in emergency room and urgent care visits.